Good morning, everyone. First of all, I'd like to welcome our fellowship candidates, applicants. Welcome to UNC, and hope you enjoy your day with us. So it's my pleasure to introduce someone who most of you know, but I'll, as usual, introduce our faculty formally for those of you who are new to this Zoom conference. So Dr. Lisa Hightower-Weidman is a professor in medicine and health behavior at UNC. So Lisa went to med school at University of Virginia and completed her residency at Stanford University. She completed 3 years of her ID fellowship here and then earned her MPH in epidemiology from our Gilling School of Public Health. She's been directly involved with the management of HIV infected and at-risk adolescents and adults at UNC since 2001. Dr. Hightower-Weidman is an expert on MHealth, which you're probably going to hear more about, social media, and utilization and evaluation of technology-based interventions to address the HIV care continuum, particularly among young men who have sex with men. She's published over 100 peer-reviewed articles on these topics, and she's well-funded through the CDC, NIH, and HRSA. So her research interests include HIV prevention on young MSM, using both the internet and other mobile technologies and interventions to incorporate game-based elements and social networking to change behaviors. She's also the PI of ITECH, which is the UNC Emory Center for Innovative Technology across the Prevention and Care Continuum. This grant, part of the Adolescent Trials Network for HIV Interventions, or ATN, seeks to develop a technology center to address the domestic epidemic of HIV among at-risk and HIV-infected youth. So this title for her talk is Innovations in Digital Health Technologies for Engaging Youth in HIV Treatment and Prevention. Thanks, Lisa, for giving this talk.
Awesome. Thank you, Arlene. All right. Well, I haven't actually spoken at this conference in a few years, so hopefully I have something new and innovative to share with you all. If not, that's problematic. But I just would start by just again reflecting on information that's pretty widely known out there around kind of the usage of mobile phones, particularly among youth. And even just kind of among adults. I thought it's pretty interesting that, we open our phones about 160 times a day, which is quite a lot. Over 2,600 times we kind of swipe, click, do something on our phones. So, and spend about 4 hours and 10 minutes of our day. So again, lots of time we could be much more productive, I think. But still, again, throughout the US, but also globally, the usage of MHealth, smartphones, social media continues to increase and really is pervasive. I think, when we think about kind of social media, and the changes over time, there's definitely different patterns of usage sorry, I have a puppy here who's wanting to get out. There's different patterns of usage for adults and kids over time. And we see this if we look at this social media brand usage, with increases in platforms like Snapchat and TikTok for young people, and decreases in the platforms that maybe some of us are more likely to use, like Facebook and other ones like LinkedIn. Insta is still pretty popular and probably one of the most popular platforms for adolescents and young adults. And often they have multiple platforms or multiple kind of logins within their social media accounts. So this is just showing kind of some of the first Instagrams, first Twitters, and really, if you think back to kind of the beginning of social media, it was probably really around the time of Morse code. And if you actually translated that to kind of the first tweet, this is what Samuel Morse would have been tweeting. And I think perhaps some of us may agree that he was certainly perhaps right in what he was saying in his initial Morse code. So when we think about MHealth overall, I think it's really important to not just sort of assume that it's the right choice in designing the intervention, but really thinking about what the health behavior is that you're looking to change, and deciding why MHealth is the right solution, why it's better than other options, and then what has already been done. And again, when I first started doing this work in MHealth, it was actually eHealth. It was kind of the smartphones. And there hadn't been a lot done. So, really you could say you were going to do an MHealth project and you would get a high innovation score in your grant. Now, again, if you say you're going to create another app or do, another MHealth study, that in and of itself is probably not innovative. And so you really need to think about, how you're using what's been done and really enhancing and building upon that to show innovation and as well as kind of to prove that, what you're proposing is significant and needed. When you think about different, technology-based platforms, again, primarily for the most part, even in global settings, most folks do have access to smartphones. Now, what's more kind of important now is that many of the smartphones, are older models or have low levels of memory and data, which makes things run kind of slower. So it's, at this point, while a lot of the folks that you might be doing work with have smartphones, it is still important to understand the types of smartphones they have, whether Android, iOS, or other, and how much data, what is their version, not just whether or not it's a smartphone or not. And there's lots of different technology-based approaches, and this is, certainly where some of the innovation can come in. But even things like SMS type interventions can be made more innovative, by enhancing the types of messages, the timing of the messages, and really kind of or linking them to behaviors that youth are doing in innovative ways. But there's all kinds of different types of technology-based approaches, ranging from SMS to using apps to using and doing work on social media, telehealth, which, again, certainly I think people became more aware of, more comfortable with during this, COVID pandemic, and other types of using kind of the internet to connect with, not only doing research, but also, patients. There's obviously all kinds of different types of sensors, wearables, digipills, as well as electronic adherence monitors. So, again, when you think about what you're going to be doing, and these can be combined, with different in-person types of interventions as well. The key things that we've sort of been really doing within our group is trying to figure out how do we continue to make our interventions engaging, because engagement is critical to impact. And we know that tailoring is really important. We know that encouraging and fostering support, inclusion of game-based elements, which again have been shown to increase engagement, but certainly aren't enough. So in and of themselves, but they're sort of needed. For the most part, people don't do anything anymore that doesn't have some degree of fun, and unless they're mandated to do it. And so, really that piece of it really is almost like required, but not sufficient. So provision of self-monitoring and feedback, and then inclusion of push factors, reminders, notifications. Again, I think, all of us would say that without reminders or notifications, we would be missing a lot of our meetings. We would be, not taking our own medications. I would continue to forget to pick my children up at school on the days they have after school activities. So I think, all of these things are sort of requirements, but taken together may not even be sufficient to continue to keep people engaged in our interventions. So when we think about the modality, when you think about youth, really, heavy text-based interventions are just, they're not going to be looked at. People only remember 20% of the text they read without some sort of visual cue. And so really kind of, as you're thinking about tailoring and what your intervention is going to do is really remembering that, there's a lot of information you want to share and get to your population, but they're not going to remember it. So, really sort of using text wisely and then supplementing it with things that are more memorable and meaningful, like videos, memes, GIFs, emojis, things that are consumable, things that are shareable. And again, this highlights, if you think about the channels, the social media channels that youth are using, the top two being Snapchat, TikTok. Those are highly graphically appealing and visually robust sites. Really, TikTok is all about videos. So again, it aligns with kind of what youth are consuming. We also know, and again, and probably don't need to do additional work to sort of ask folks what they want in HIV prevention type interventions. It doesn't mean that we don't need to continue to do formative work in some way, shape, or form, but I don't think we need to continue to ask these same questions, because these are the answers that we've gotten, and we, being the collective, research world, asking these questions globally around kind of what people want. And they want to have connections to peers and providers. They say they want discrete reminders. They want provision of comprehensive, holistic, accurate information. They want some sort of games, rewards, incentives, and they want careful attention to privacy. Now, whether or not they use all of these features, even if you build them and put them in an intervention, is debatable. And how and what, how you kind of facilitate these types of things is, I think, the places where, formative work with unique populations can be useful. But I think kind of at least starting from this framework and from this, this base allows more and more useful information to kind of come out of it. So as Arlene mentioned, I run ITECH, which is in its 5th year, and as part of the Adolescent Trials Network. And through ITECH, we've actually running 12 different types of studies, the majority of which are using technology to address kind of one or more steps in the HIV care continuum. We're currently at the place where almost all of our studies are fully enrolled, or realizing that they're going to maybe not fully meet their enrollment targets, and that's certainly a byproduct of COVID, but pretty close to fully enrolled for almost all of them. And so we're at this great space where we're actually going to be able to start getting information out around how these different tech-based interventions impact HIV prevention and care. Overall, we've enrolled about over 3,200 participants in our studies, and the majority of which were enrolled in RCTs to test these various different apps. And, again, we're not the only group that's doing this. This is, a lot of interventions have been kind of put out there, which is sort of gets to some of my point, which we'll talk about later, is where and how to go from here, in that we have, on this side alone, 20 plus interventions that are being tested and evaluated, and really what is the sustainability and the next steps for these interventions. But there really are interventions that address kind of all phases of the prevention and then care continuum. The ones in red are ones that our group is supporting. But again, there's others that are out there that aren't included on this list. So P3, or Prepared, Protected, and Empowered, is one of our interventions through ITECH. And this is a PrEP adherence app. Again, this was developed through work with a company that myself and Kate Messig were working with, Yogo. And we created P3, which is the app for PrEP adherence, and then AllyQuest, which is an app for ART adherence, which Kate is testing in a pilot RCT as well. We enrolled 246 youth throughout 9 of our ITECH sites around the country. We have really great retention, which is exciting. Our collection of dried bloods, the trial was initially designed to be in-person visits at baseline 3 and 6 months, with collection of Mitra samples for dried blood spot assessment of PrEP adherence. Obviously, the coronavirus had something to say about our ability to do that. We pivoted. We shut down enrollment in March and continued follow-up remotely, and then pivoted to fully remote enrollment and follow-up, and we're able to open back up by July. So we have less blood spot specimens. We have about 55% at each time point, 70% overall, but still, I think, pretty impressive given the coronavirus pandemic. We have our analysis in progress, but I think at first blush, usage of this app was very high compared to what we've seen in some of our other studies. So high usage, the majority were high users, with some medium users, and only about a quarter were low users. And again, this is probably a flip to what we've seen with some of our other studies and other apps out there, where the majority, around 25%, tend to be in the high users. So I think we're really excited. Early data looks pretty good around adherence. Obviously, we'll have to wait for Mackenzie and the lab here at UNC to run our analyses, but with dry blood spots, and we'll have to do some unique analyses to try and account for some of the missing samples, but we're excited to see how this app does in terms of PrEP adherence. We're also running some studies looking at youth living with HIV. And so the Thrive With Me app was developed for adults. by Keith Horvath, who's at San Diego State, and was adapted within ITECH for youth living with HIV in an app called Youth Thrive. So, it's certainly challenging. We've had a lot of challenges enrolling youth living with HIV, again, even greater during the pandemic, but that one is still actively recruiting. We've enrolled 158 youth living with HIV throughout the US at about 10 ITECH sites. And then our Tough Talks app is a study that we're doing through our BAT lab here. We just closed to enrollment. We ended up enrolling about 80% of our proposed sample, which again, I think is exciting. This is being run by one of my project coordinators, Zach, and we're again getting ready to look at our data. But this is an app that is delivered to help youth disclose their HIV status, with the kind of the idea that disclosure can increase social support, can also increase self-esteem, can increase confidence and self-management, and by helping youth realize and actualize whether or not they want to or need to disclose, it can actually help them engage better in care and promote viral suppression. So more to come on these two studies. But as I said, below or before, the issue is that there's the potential kind of for really broad dissemination and impact is lower than we would like. And, again, from my own perspective, we have not yet been successful at scaling up these interventions. And I think, that is really kind of where we need to really think about what is, how do we do that? We need to focus on user engagement. We need to kind of think about content development and management. It's, the way that we do this with our apps. And again, this is not just across different HIV, continuum areas, but also really kind of in the greater kind of digital health intervention world. A lot of our interventions have the same content because we are creating, what we think of as holistic content for youth, particularly in our group, sexual and gender minority youth. But that content is relevant for youth, again, maybe where HIV isn't the outcome, but maybe mental health or depression or obesity. So, smoking, drug use, all of these things are using similar content, and everyone is starting from scratch and creating it. And that's highly inefficient and time consuming. Again, few interventions are actually created that can sort of efficiently incorporate new scientific knowledge. So, science is changing, and we certainly know this, right? For those of us that obviously believe in science, which are hopefully most of you on this call. But, the important, when we do these interventions, we have to make sure that they're flexible, because you can't, the minute you have a fact that's no longer true, you lose credibility with your target audience, particularly youth. And so you need to be able to change that. And in terms of kind of how we build a lot of these interventions, we don't account for that. We don't account for it in the funding or actually in kind of the planning of how we're actually building them. And again, there's been a lot of grants, I've received a lot of funding to develop these, programs. And again, I haven't yet gotten to a space where there's been widespread dissemination. I think that's a failure. And we need to improve upon that so that we can actually be good stewards of the investment that's being made. And, again, one magic app will never exist, and it doesn't exist. And, as some of you on the call know, Claire Farrell, I'm a big Dolly Parton fan. And so this was the Dolly Parton challenge, where she kind of put, how she looks differently, how she presents herself differently on different apps. And again, there's lots of different apps out there, and youth use them all, and they use them all for different reasons. And so, for us to think that we can create an app that's going to kind of, address all of the, issues that someone has over time without being flexible, without responding to their changing risk profiles, to their changing developmental needs, we're not going to end up being successful. And so I think, as we move forward, we need to be thinking about, a platform that allows for more user customization, that allows for more real-time engagement through a menu of interventions, or, through customized content or features that can, are relatively are needed at different times. And that's sort of where we have been going within our group. And it really kind of builds off of our health empowerment platform, which, was work that I started doing as part of a K award. So a long time ago. And again, when we first built health empowerment, it was, I think, one of the first actually status neutral interventions. It was sort of status neutral before that was a term, and which actually caused some consternation because they didn't know at the time the study sections at NIH were sort of divided by primary prevention and secondary prevention, which is what they called it. And they didn't know where to send it because it was enrolling both youth living with and at risk for HIV. But it was at the time, it was a mobile optimized platform, sort of the beginning of MHealth, kind of a little bit pre-apps. And it wasn't, didn't have a lot of social connection because again, it was sort of, we built it sort of pre-Facebook, sort of even pre-MySpace, if you remember back then. But it did, offer some activities. It did offer connection with the provider. That was me as an Ask the Expert. And it did offer, a forum kind of space where folks could, have post information and things. But again, very kind of basic compared to kind of where the youth were moving in terms of how they were using social media. But we did find statistically significant reductions in condomless anal intercourse, which was the primary outcome. Again, this was kind of designed pre-PrEP. And so that wasn't something we even measured. And then in secondary analyses that were done, we did see increases in HIV-related communication, other HIV-related care outcomes, decreases in stigma. And so, we really kind of, realized that there was sort of, something here in our platform. And however, kind of along the line, we also had a lot of other different projects, like I said, these sort of standalone apps where we learned other things around things that were important. So we had other apps that we developed that, again, looked at self-monitoring and feedback, looked at HIV self-testing, again, looked at disclosure, our tracking apps, et cetera, et cetera. And throughout this time period, we also realized that even when we found successful apps, if we didn't have the perfect match with a company, the app, almost has a shelf life that would expire before the trial ended. And I say this because the company we were working with for P3 and AllyQuest that we really had invested a lot of time and energy with, you sort of let us know mid-trial that at the end of the trial, they would no longer be supporting the platform because their company was moving in a different direction. And so, it's a little heartbreaking to know that you're doing a study, but yet even if you find it to be effective, the app is no longer viable. And so we really needed to start thinking about how to avoid that in the future. And so we really thought about how can we actually partner with a company that has kind of the same belief system as us and get to a space where we can create something that is sustainable and that we have more control over in terms of the sustainability. And so we were lucky enough to partner with a company called OneCal Standing, which is actually in Durham. And so we were able to kind of get together before we stopped being able to do that. And was a partnership with us to really kind of think about how we can create the health empowerment or HMP platform and work to really build upon it and leverage this platform for that we would make available to other researchers, to other intervention studies, that we can get to a space where we can actually, create more customization at a reasonable and faster turnaround time to actually kind of get to a space where this becomes something that has sustainability. And, we think about this again, we're certainly not, Apple by any means, but, I've gotten some feedback of, why is HMP still around? This is a platform that's been around since 2011. And that, to me is actually a success, right? No one would say, why is the iPhone's been around since 2007, why do you still use it, right? The idea is that shows some sustainability and that we've been able to continue and build upon this platform for many years. And again, similar to the kind of the model is, how do you make it more usable and more engaging. And really that's kind of what, what this model is of the iPhone is that, what works, what doesn't work. How do you kind of continue to improve on it? How do you make it more, for them, obviously more something that people want to buy. But, again, for us, how do we make it something that is easier to adapt and to make useful for other researchers? And so we've been able to really do that. H&P is now available as an app. So we've moved from mobile optimized to app-based. And we're currently supporting multiple studies throughout the US and globally, including stigma reduction, which is a US-based study, PrEP uptake and adherence, which is, again, stuff that we're doing in Los Angeles, but also in South Africa, and as well as Romania. We're doing ART adherence, engagement in care, working with transgender community health workers, Tony Petit's group, and then peer support, social capital with researchers in Alabama and Georgia. And I would say that, that 2 of these grants are actually supporting trainees. So on K awards, and again, the K award budget is for research is very, very small. So the ability to actually put a fully functional platform in the hands of a K award person and allow them to customize it for their study, I think is, again, the whole kind of one of the whole purposes behind having a platform. And so again, over time, we've really kind of improved health empowerment. Again, I won't go into every single feature of it, but we really, try and continue to add different features that and enhance them. And that's the whole point. So, if a grant that I get, is able to customize or enhance one of the features, then that feature becomes available for everyone else who is currently using the app, who wants to add that feature in, or for the next people down the line. So the idea is that you just continue to build and then make those things available so that you're, hopefully making better use of the money that you're using. And so again, we have a lot of different features. But again, what we've done is really think about all those other apps we've developed over time. What are the things that work? Again, in the P3 app that I talked about with PrEP adherence, what we found is the most useful feature is this medication tracking. And so, making sure that we, as best as possible, reproduce what are the features of a medication tracker that will be most influential in use. Again, we've talked about sort of this goal setting, which is some other apps that we've had, activities, posts, things like that. So with each step, we try and kind of, again, incorporate what we know from looking at data are the features into this comprehensive app. And this just shows, again, some ways that it can be customized. So the idea, again, every one of these home screens is actually doing the same thing. It's either sending surveys, or showing your analytics, or tracking your health, or looking at activities. It's basically just modular. And so it looks very, very different, whether it's for, youth in South Africa, or youth in the US, or in Romania, or in Peru, et cetera. But that is kind of the idea, is that you can kind of, build and make things look different, but, by doing it through their kind of this modular way. Again, this is the current medication tracker. We just received a U01 from the CDC that started this month that we just got. That's going to be around looking at PrEP decision making and for different PrEP modalities and PrEP choice. So the goal of that grant will actually be to really enhance this medication tracker so that it's very flexible to different dosing strategies, long acting, injectables, 2-on-1, et cetera, et cetera. But this is the current medication tracked. We also track behaviors that again, this is customizable. So this you can check. This is for our South Africa app, so they track finances. But again, we know for our Romania app from some formative work that they really want to have more tracking around smoking, because that's a very big thing in Romania, and different types of alcohols, et cetera, et cetera. So again, the idea is that these are the places where you can really customize the app for your population without having to have kind of a heavy lift on the side of the developer. This is our goal setting feature. This is a feature that got added from an R34 that we have with a group in LA, where it's really about PrEP uptake. And so we really wanted to have a lot of goal setting to really kind of help people along a prep uptake journey. But again, this goal setting feature now becomes available to all the different apps, and you can have a goals around anything. And so again, my K Award mentee in South Africa will be adding goals around ART adherence, and that's for perinatally infected youth in South Africa. A colleague that's working on a grant that is really focused on LGBTQ mental health and suicide prevention is going to be adding goals around that. So but still have access to all of the goal repository that we've already developed. Here's just some of our game-based elements. So within the app, we have badges, we have badge sets. These can be tied to real life tangible rewards. So, where you, when you unlock different badge sets, that could lead to rewards that you get in person. And again, these are things that can be customized to different activities within the app. We also have an avatar customization tool. So this is for our South Africa grant. We're currently working to develop one that's more for youth in the US, but you can see this really, you can get as detailed and as customizable as to the eye color, eye shade. I mean, so many different features that that you can do and have different things that unlock over time. So lots of, again, different things. The question becomes, how useful is this feature? Is this something that, that to increase engagement is worth really investing in for a group, or is sort of a basic avatar system enough? And that's, again, where I think some of the formative work can be really important. HMP also supports kind of a back-end administrative dashboard, which again is really important for trial, conducting trials. So the ability to kind of integrate surveys, send push notifications, have communication. There's a test kit portal where people can, request and receive, testing kits. Again, that can be used for, everything from, HIV tests. We put in a grant, we didn't actually get it, which we were actually combining HIV and COVID testing, and that, the ability to add home-based COVID testing to that as well. But again, really kind of any types of testing, tracking, whether it's, adherence, et cetera. And analytics, again, we're continuing to work on making these more useful, making these more real time, because again, if you're doing a study, it's really important to think about engagement and decide what you're going to do if folks aren't engaging with the intervention during the intervention, rather than waiting until kind of the end. And so that's sort of where we are with HMP 2.0, but we're moving towards HMP 3.0. And this is really kind of, I think for us is kind of thinking about what are the, other things that we should be thinking about in terms of making this a really a platform that is kind of the sort of highest and most sophisticated system. And I think that really does include thinking about more adaptive tailoring and machine learning, and thinking about content recommender systems, which really are, pervasive in everything we do. Anytime you get on, get online and see an ad, for something based on something you've bought before, that's content recommendations, or Netflix, watch this, watch that. So, how do we kind of maximize what's being done in the real world, I say, to what's being done in our world? And so there's lots of different ways to tailor information. Again, personalization is sort of, again, making the information seem more relevant to the recipient. Welcome back, Lisa. We missed you. Again, it makes you feel like, oh, they're thinking of me. Feedback, providing individuals with information about themselves or others throughout. Oh, we see, Lisa, you're drinking too much. Or, we see every time you're drinking, you're not taking your PrEP. Maybe you should talk to your doctor about that. And then content matching, again, figuring out what that person would like based on what they have already watched or looked at or read, or what folks like them like. And again, that's kind of what you see with Netflix and other types of recommender systems, Amazon, et cetera. So that's kind of what we've been doing currently. HMP currently, again, we have over 1,500, probably more, with our content team that tailored pieces. And so what we've really been thinking about is how do we enable reuse, sharing, and adaptation. So, if we have an article or, piece of content that was written for, young MSM in the US, tweaking it for, young South African women, may just require changing, certain pronouns or different names of things. But the information around ART or around PrEP, et cetera, is probably the same. And so, having, the ability to kind of tag that information and quickly and efficiently make those changes for reuse is really critical. In addition, things change, right? So when we initially wrote much of this content, the only medication available for PrEP was once daily Truvada. And so, when Descovy was approved, we needed to go in, and every article we mentioned Truvada, either, describe Descovy as well, or, adjust it. Similarly, there will soon be an, injectable PrEP. And so do we need to go back in and again, make that change in 211? And so, again, really being aware of what places may require updating, having a really good content management system allows you to do that better. And so we have a SBIR grant that we put in September. So we'll see how that works, but the idea is to facilitate this this content management system that would be available at scale. This content management system would also allow for different types of tailoring, both rules-based and machine learning tailoring. So rules-based tailoring, meaning that there's certain rules based on surveys or information that we collect at predetermined intervals around what folks are either kind of their current risk, their current interests, and provides information based on that. And then machine learning is again really kind of more dynamically tailored content in more real time. And again, that comes from either information that we already have on users based on prior users of HMP, as well as kind of what users are doing in real time on the app. And so again, we'll see if we get this grant, but the idea is to create this more robust content management system, which would allow for more tailoring and content recommendations, which again would make the app much more usable, but also would allow for content to be used in other ways. So people could use the content to spit out information for other type. It wouldn't have to go directly to the app. So you could again spit out content for pamphlets or brochures or other websites, etc. The other thing is that is understanding and connecting kind of to the real world. And so a lot of we're limited in understanding what people do in our interventions based on how they're using our interventions. And we know that they may be acting differently, right? In a forum for health empowerment than a forum, that they're on with their friends or even, just sort of social media in general. And so, how can we actually look at what they're doing in the real world and meaningfully turn that into interventions or information that is used to deliver interventions. And this is, again, work that's being done for, a lot of different ways. But again, I think that the key is that, what people found, and this is, it makes sense. We've seen this with all kinds of things. What people do and say on social media is what they do and say in real life. And, and that, we take it seriously if somebody talks about suicide or killing someone, right? Is that those, that is, reflective of perhaps where they are. Similarly, is that, again, if they're talking about sex or they're engaging, substance use, they're probably engaging in it. And, if they're, promoting stigmatizing, information, how can we again use that to, to address, misinformation and things like that. And again, this is important, obviously, in HIV, but also certainly in COVID as well. So again, there's a lot of ethical considerations, although for the most part, people are pretty agreeable to letting you utilize their social media data. So again, this is something that, we've incorporated in this grant of again, can we also use what people are doing offline or, outside of our interventions to impact what we show them within our interventions. The other thing, we've been working on are adaptive interventions. So the idea of understanding where, the kind of just right sweet spot is in terms of intervention delivery. And, again, figuring out how we can respond in the right time with the right intervention. This is a study called Poems that we've been doing, PrEP Options Exploring Messages to Plan for Sex. This is a study that we've been looking at to really kind of understand how youth, how and if youth can actually and accurately predict their sex encounters. Again, if they can or can't, what sort of factors are associated with that, with the idea of, can we think about the types of interventions that we can deliver just in time, meaning kind of around the time that youth are planning for sex, or maybe again, increasing their ability to plan, to ensure that strategies like 211 PrEP or event-driven PrEP are useful, or alternatively, can we kind of understand better if those types of strategies are actually useful in this population. And so the idea is, again, is to understand a lot of the different factors that certainly would impact prediction and planning, like executive function, impulsivity, sensation seeking, et cetera. And so we did a study with 120 young MSM, where we did a EMA, ecological momentary assessment. Again, this is another study run by our team, by Zach. I say that because that's Arlene's son, so I want to make sure he gets bonus points. They asked about the likelihood. We asked about the likelihood for youth of having sex in the next 24 hours. We asked about it in 2 different ways, kind of a like or not at all likely to very likely, and a verbatim scale, which is a percentage. And then we asked them if they actually had sex in the past 24 hours or looked for sex online. And if they did have sex, we asked them questions around the number of partners, behaviors, et cetera. We also asked them how sort of long before they had sex did they know they were actually going to have it. So we just finished enrollment in this study. And again, we're starting to analyze the data thanks to one of our graduate students, Bryce and Kim Powers, looking at the data. But what's really exciting is that of the 120 young men who were enrolled, the retention in the study was 99.2%. So 119 of our 120 did both the baseline and follow-up, which was at 2 months. And our EMA completion, I've never seen results like this ever, was 98%. So of the potential 6,720 responses, we got 6,570. Again, I actually didn't believe that this actually happened until we saw the data, because it's just so much higher than other studies have shown. And in 12% of these daily EMAs did the youth report that they had had sex in the prior 24 hours. So that was about 845 sex events and 952 sex acts. So we have, again, data on 1,000 sex acts. And I think, again, this is very early data, literally hot off the presses from yesterday, but I think the key thing is that the majority of these young people are not knowing that they're kind of going to have sex. There was 71% sort of knew about it about less than 2 hours before. And again, for 2-on-1 type sex or type PrEP, you really need to be kind of take it 2 to 24 hours before. Again, a lot of different types of partners that, and then when you look at the type of sex people are having in these different sex acts, again, the majority is condomless. And so I think, really important, for us to be understanding kind of, sex, and I think understanding it at this nuanced level is really, is important. The final piece, just to kind of switch gears for the last piece, is just to not leave, not to sort of fail to mention kind of, I think, we've learned a lot from HIV interventions around using digital health. And so we did apply that information to COVID. And we received a grant from NIMHD to address COVID vaccine skepticism in African-American young adults in 3 southern states, North Carolina, Georgia, and Alabama. And again, realizing that we don't want to start from scratch, we're building this platform off of our Tough Talks platform, which was our platform around HIV disclosure. And so again, how can we maximize what we've already built to more expediently get these interventions in the field? This Tough Talks COVID is built off of the NIMHD research frameworks, which we adapted to reflect the SAGE working group model of vaccine hesitancy. And so really kind of trying to understand and address different individual, community, sociocultural, et cetera, variables that impact vaccine skepticism and hesitancy among young adults. Again, this is our Tough Talks main platform. And so you can see very engaging, very colorful, a lot of really interactive activities. And again, we're just modifying this with data and information related to the COVID and COVID vaccination for young adults. And so we're in the process of doing a one, which is an online survey, which tries to understand even more in depth around youth vaccine decision-making through kind of more engaging questions around kind of choosing your own adventures and understanding how youth make decisions, not just whether or not they will agree to a vaccine. We'll then be doing a digital storytelling workshop in the next month where we actually create videos that then become part of the intervention. In the meantime, we've been developing activities. Again, this is being led by Christina Toval and my group, as well as Audrey Pettifor, Alicia Mark Bass, Hannah Budwani, lots of folks at different institutions, FHI, RTI, UAB. Again, we'll then aiming to get this in the field within a year and a half, which again is an expedited timeline requested by NIH given the issue of the pandemic. And again, this just shows kind of a module overview with screenshots of one of our animated videos. Again, the first animated video is really around the history of vaccines, but the history of vaccines and the celebration of science, including the role of Black physicians and researchers in kind of making and achieving the successes and the the work that led to the vaccine development. And so I think really kind of highlighting the role of Black people in science, and that really is the theme of this entire intervention, is around kind of celebrating the role of Black people in science, but also in being able to make their own decisions around vaccine uptake, and really kind of coming at it from that point of view of providing information to make informed decisions rather than being patronizing about kind of why folks are skeptics or have skepticism around that. So in summary, I think, really in terms of ending the epidemic and really kind of addressing HIV, that, technology plays a role. It has to, whether it's the intervention itself or whether it's the means of engaging with folks through social media or doing follow-up visits or telehealth. All of these things, I think, really does require sort of an intentional, integrated, personalized response where technology is part of it. And so, the question is sort of, how do we kind of really maximize the engagement in these platforms to really kind of achieve an impact? And I think we really need to be thinking more about, stopping kind of this focus on these one-off interventions and really start to think, more. Again, and health empowerment isn't the only intervention platform that's doing this. There's other groups that are really trying to think about how to build upon what's being developed rather than building anew. And again, I think that's really where the potential is to really kind of actually create sort of meaningful change at a scalable way for addressing, again, not only HIV, but other, chronic or even acute health conditions that youth are facing. So obviously there's too many folks to thank, but certainly all the members of my Bat Lab group who may or may not be on this call, but also lots of collaborators throughout the many institutions. So I thank you, and I think we have a little over 10 minutes for questions. So I can stop sharing.
Yeah, thank you, Lisa. Again, an amazing amount of information and incredible work that you and your team are doing. It's really mind-boggling, to be honest. So I know that there's a couple of questions already. Maybe Claire, if you're still on, maybe you want to ask your question directly.
Sure. Lisa, that was fantastic. I think Dolly would have really enjoyed it. My question was whether or not there's any interest in having any of and the adherence data or symptom data or anything like that shared back to providers via the EMR or some other mechanism. I wasn't sure whether that was totally taboo or whether it would be motivating.
Yeah, it's interesting. So we've talked about this a lot, and around kind of connections to EMR way back in the day. Even I think with Amy and I, like when Epic first came, we had meetings with the Epic people. We were going to like create our whole, we were going to create like my chart before my chart, I think. And so it's interesting because when you ask folks about that connection and about sharing, they say yes. But then when you actually in practice, they don't see it as much. And so what we've sort of seen more is that, wanting to be able to reach people, providers when they want to be able to reach them. And I think probably everyone in our clinic will say like, yeah, duh. And so what we've included, at least in health empowerment, is sort of a communication portal. And so whoever sits on the other end of that portal, it really just depends on the intervention you're doing. And so for, one of our studies, we have a PrEP navigator. For another study, it's somebody in the clinic. And so it really just, you can put it through there. And so that's sort of where we are. We've, again, talked about integration many times, but it just becomes complicated. And so we always end up at this like, because if it's Epic, you still have to go through a lot of the different, and that changes all the time. There's ways to connect, but it is something where we've sort of made it. We have not, I should say, gone down that kind of the full integration of things. There are other platforms that have Positive Links, which is a group that isn't UVA that's done this, has done more about connection with the clinics and having kind of clinic-based launching of their apps. So it is something that is being done though.
Okay, are there other questions from the audience? So I know there's one in the chat. So question regarding how did you decide on the age range of participants that you want to include in each of your studies? Because you did have different age ranges and all of them are considered youth.
Yeah, it's a great question. Some of it's just sort of random, either, sometimes based on the RFA of what, what's being asked for a grant, opportunity that we're applying for. So for instance, this new CDC grant we just got, we can't actually go under 18. And so we're, going 18 to 39 for our Tough Talks COVID grant. Again, they didn't want us to go under 18 because at the time, vaccines weren't approved, so it's sort of like some of it depends on the RFA you're applying for. To be honest, some of it is a little bit just nuanced of what you think the reviewers will buy in terms of across a developmental age. So, can you really sell that you're doing, that this intervention content is, will address the needs of a 16-year-old and a 26-year-old or and a 30-year-old. So sometimes it's really around kind of the type of intervention content that's being delivered and ensuring that really what you're delivering is going to be relevant to the age groups you're including. So that's why I think it looks a little maybe random or schizophrenic, and not is because for each study it's sort of a unique we think through that and decide it. And to be honest, sometimes we then change it. As folks will know, I'm the queen of changing the eligibility mid-trial if you're not successful in recruiting, and thinking about like, is there any reason why we can't expand from 26 to 29? Like, and things like that. So sometimes you do what you can to kind of make the study successful.
So I had a question regarding, sure. I guess more of the downstream effects of your apps. So, you talk a lot about retention and of course, about adherence, but I wonder if you've measured outcomes like mental health or social engagement, so long-term effects of using these apps. Yeah. And then I have a follow-up question to that.
Yeah, definitely. I think, I think a lot of the Vet Lab feel very strongly that we should be, that's really where some of our apps are most effective, honestly. And some of the qualitative work that Kate and others have done really highlights that. It's really, some of the comments that we get from people after using the apps are really, again, it makes it sort of worthwhile. I mean, I know I don't say that sort of sounds like kind of trite, but it really like, it's really makes you feel really good around kind of that these apps are providing something that they aren't having. So we do measure it in all of our apps. The issue is like, can we, is how we can get, NIH to really elevate things like stigma to a high priority, outcome. And that, I'm part of a working NIH group that really kind of, talked about that. But I mean, that's really kind of, the issue is that, getting funding for a lot of these requires for these biologic outcomes, which are important. And I'm not saying they're not, but, the other longer term things like mental health, social support, stigma reduction, obviously we know all of those things are what impact success in terms of adherence and long-term, suppression or prevention.
Yeah, I totally agree. So Gail Henderson had a question. Have you worked in resource challenged parts of Africa with people who are hard to get into care at all?
Yeah, I mean, so I would say probably no, in terms of like the groups that we've worked with in South Africa so far have been is Linda Gale's group. So I mean, so it's not necessarily I'd say the fully kind of remote areas that we've been doing. So we're working with her group or clinics around in and around South Africa as well. So I would say that so far we've partnered more with sort of clinics and things that have populations, but we would certainly be willing to, and we've talked with other folks and around kind of using the platform. And we're really, I think, thinking about though how to, we've come into a lot of issues around making the platform accessible for folks in South Africa or places where, again, the phones may be older and slower, how much, don't have, a whole lot of memory, but also, don't have high wireless, don't have access to Wi-Fi all the time. And so really trying to figure out kind of what pieces of the platform need to be available when somebody's offline. How does that also though impact the speed of other, information that they get? How do we, kind of maximize the ability to use these there? And I think we've learned a lot from doing those different projects.
Are there other questions from the audience? I do have one more. So I love your discussion about sustainability, right? About scaling up, dissemination. So I wonder if you can, again, if you could put on like your magic hat and just say, how do you break that, like from studies to implementation, and into actual real life use? Like, thinking about public health departments, this is still uncharted territory. Use of social media, or do you focus on the companies, which you already said? I think what you're doing is incredibly important. It's just, how do you get it out there and acceptable?
Yeah, no, it's great. I mean, and I, if I had the magic answer or a magic hat, I'd wear it all the time. But I don't. But I think I think about kind of how does this sort of, what's happened with like in-person interventions, right? How do we made some interventions sustainable? I mean, a lot of that has gone through CDC, right? Sort of creating like these evidence-based interventions, which they put a lot of money behind to like come into a clinic or, a CBO and, have them implement, many men, many voices or, clear or whatever, right? Like, and they have technical assistance and, they give agencies money to do this. Why is that any different than like a successful MHealth intervention? Honestly, the TA is probably less than is required to do a 8-session in-person clear intervention, et cetera, right? And so, I do think that, if we could get to a space where, these interventions were kind of, bought into by things like the CDC, which is really where we, is who does the implementation work. I mean, NIH will, even we funds implementation studies, they're not really there to fund kind of long-term implementations of interventions. Then that is really kind of where we need to go, because the interventions themselves do need to be sustained and maintained. And so, And, and so I think that there's sort of that piece around kind of buy-in that they're useful. And then there needs to be some sort of public-private kind of partnership that sustains them, because, you do need kind of maintenance and upkeep, and, regardless, and you need to be flexible to science, and, and so, that requires, time and effort, as, my folks that work on the app know. It takes, it just doesn't magically, even though it's, tech, it doesn't magically change. There's a lot of like actual manual work that goes into kind of keeping the content fresh and updated and stuff.
Yeah, excellent. Yeah, thanks again. And congratulations to you and your bat lab, 5 years of ATN work, which I know has been somewhat of a struggle, but you've been incredibly productive. So thanks again.
Thank you. Thank you.
So for next Friday, I will have Dr. Wei Ming Tang. So some of you know him from UNC Project China, but he's now moved to Chapel Hill. He'll be discussing pay it forward approach for HIV and STIs. So thank you very much, and see you next week.